Okay, so this is cranial nerve 8, vestibular cochlear. It is a sensory nerve. It originates between the medulla and the pons. The vestibular branch gathers information about head position with respect to gravity and head movement. And the cochlear branch conducts auditory sensations from the inner ear. So you can take a look at the picture and you can see that vestibular cochlear nerve as it has two different branches. It has that vestibular branch that's getting information from the semicircular canals. And then you can also see the cochlear branch getting information from the cochlea. And of course, when you look at the title, vestibular cochlear nerve, it's actually in the title, what type of information it gives you. It gives you information about the vestibular system and hearing. So this nerve is also known as it used to be called the acoustic nerves. It's also been known as the auditory nerves. But now it's called the vestibular cochlear nerve. So as we learn more in neurology, they kind of update the names of things as we better understand like tracts and cranial nerves. So when you take a look at this nerve, it also travels through that internal acoustic meatus with the facial nerve too. So you can see the facial nerve in the picture. So you can see those two nerves are close together. So if there's damage or pinching or a tumor or something else, you could see how they're pretty close to each other as far as anatomy. So again, that it's a sensory nerve. It has two branches. It has a vestibular branch that gives information from that internal ear about head position and gravity, and that's the vestibular piece. And those, of course, are really important for our sense of balance, right? We want to know where our head position is in relative to both gravity, and that really impacts a patient's balance. And the cochlear branch here is giving information about hearing. So this is cranial nerve 9, the glossal pharyngeal nerve. It's a mixed nerve as well, so it's carrying both sensory and motor information. It originates in the medulla. It carries general sensory information from the lining of the pharynx and the soft palate. It carries visceral sensory information regarding blood pressure, chemical information from that carotid artery, as well as taste from the posterior third of the tongue. It carries somatic motor to the pharyngeal muscles for swallowing, right? Super important. And visceral motor to the salivary glands, which is also really important. If you're not having good saliva, it's really hard to moisten the food before you swallow it. And it's also responsible for the afferent or the sensory limb of the gag and swallow reflex. So imagine if your patient is lacking or having difficulty swallowing, that could lead to what? Things like aspiration pneumonia. If your patient isn't effectively swallowing, they're a choking risk, right? So these are immediate questions depending on the type of stroke you've had or the damage that's in your body. The nurses and the medical team need to know if you can safely swallow food, or they may give you thickened liquids. They may not let you drink like water. We as physical therapists and physical therapist assistants, we need to know whether our patient's on swallowing precautions, whether they're on thickened liquids, because they're very good about asking us for a glass of water when they know they can't have one. So we need to know what the precautions are for our patients. So the gag reflex, so when you touch that pharynx, the physicians will touch your pharynx with a tongue depressor to try to activate that gag reflex. So they're looking here. So the next cranial nerve, 10, provides the motor signals triggering that gag. But this nerve, glossal pharyngeal, is carrying the afferent or the sensory component of that gag reflex. So here's cranial nerve 10, the vagus nerve. It's also a mixed nerve. It originates in the medulla. It is sensory from and visceral motor to the pharynx the larynx, the organs of the thoracic and abdominal pelvic cavities. So it's carrying parasympathetic fibers that decrease heart rate, that constrict the airway, the bronchi, that increases digestive activity, and that affects speech. So those are huge, right? This is a huge impact. It also carries visceral motor to the pharyngeal muscles for swallowing. And it's the only cranial nerve that descends below the neck. So if you have trauma to the neck, you may damage this peripheral nerve as it travels down below into the the thoracic cavity and below. So we test this nerve again by that gag reflex because it's the motor part of the swallowing reflex. So if a patient is damaged to either 9 or 10, so either cranial nerve 9, the glossopharyngeal, or cranial nerve 10, the vagus nerve, that can prevent the coordination of swallowing. And again, we need, the medical team will figure out whether or not your patient is at risk for that, and therefore at risk for like aspiration pneumonia, and will decide what type of liquids and food, if any. And if they are deemed to be unsafe swallowing, these patients are going on a feeding tube, which can also have impact on PT, right? Because we need to know where the feeding tube is so we don't pull it out. That's going to probably impact their energy, right? Being fed on a feeding tube is different than maybe the energy you might take by mouth. But there's also a lot of pleasure around food, right? So our patients who are on feeding tubes are not getting kind of that regular pleasure that we have around food, sharing it with families, that kind of thing. So it's a big challenge. Here's cranial nerve 11. This is the accessory nerve. It is also known as the spinal accessory nerve or the spino-accessory nerve. So if you see it written that way, right now we call it the accessory nerve. And it originates in the medulla. It is motor. It's a motor nerve. It's providing the sternocleidomastoid and the trapezius muscles with somatic motor support. So it's a motor muscle. So if this muscle is damaged, if this nerve is damaged, those muscles are not going to fire. And that, you can imagine, could have difficulty with posture and other things. Hypoglossal nerve, cranial nerve 12. It originates in the medulla. It is somatic motor to extrinsic and intrinsic tongue muscles. So it does assist in swallowing because that tongue is helping to move food back. But again, several cranial nerves are involved in the movement of food in the mouth and swallowing, and even GI peristalsis of food in the stomach. So again, all these cranial nerves have huge impacts. The cranial nerve test for this one, just so you know, is to have a patient stick their tongue out. If there is damage to one, the tongue will veer toward that affected side. So again, taking a look at these cranial nerves can have huge, if you knock out one or some of these cranial nerves, it can be catastrophic for the patient, for speech, for eating by mouth, for facial expression, for managing drool, for being able to eat by mouth. So these can be really impactful to our patients. So cranial nerve tests are important to the medical team. They're really important to our patients and have big impact on our therapy too. If a patient can't speak, you'll have to find another way to communicate, because you need to know if, let's say, if your patient has pain or is fatigued, if they are having difficulty expressing themselves verbally or understanding your question, which would be caused by something else. Those are all the types of things we need to know what our patients are bringing to the table so we can tap into those things. Okay, so that's the end of this particular lecture. So after spring break, we will start right on the brain and brainstem, and I'll also have the cerebellum lecture up and ready to go in case we get there. So have a good, safe spring break, everybody. I'll see you next time.